Good morning, everyone. I still see the numbers climbing, so I'm going to give everybody about 60 more seconds to log in, and then we will get started. All right, good afternoon or morning, depending on where you are joining us from. Welcome to today's session of the National Network of Health Surveys workshops on advancing the disaggregation of ethnic and racial data through technical assistance, training, and case making. My name is AJ Scheitler. I'm the director of the network, and I welcome you all to this very exciting conversation that we are going to be having today. Just a few preview announcements. Please use the chats for any general comments and discussion and questions among yourselves. But if you have questions for the panelists, please use the Q&A function. We are monitoring that, and we'll be answering those with the panelists throughout the workshop today. And then after our workshop today, please go on our website and complete the post-workshop survey and tell us about your technical assistant needs and if there's any other topic areas that you would like to see us cover as part of this series. The National Network of Health Surveys is a free and voluntary network that consists of survey leaders, data health users, funders and foundations, federal, state, and local agencies that work with surveys and other data collection mechanisms and want their data to be high quality, that designed to inform programs and policies at local, state, and national levels, and as much as possible collect data that is comparable to other surveys for allowing for good solid comparisons. And we work to help all of these different resources to improve their data collection through survey science, through data usability and data utilization, and we work to provide a collective voice in national policy. For this project, we are funded by the Robert Wood Johnson Foundation to help improve the collection, processing, and reporting of disaggregated racial and ethnic data, specifically with the eye to improve health equity and really address health disparities that are becoming more and more evident during these times that we are living in. We are providing these technical assistance workshops. We have a whole series. We have them archived on our website if you missed any of the past ones and would like to catch up. And we have one more planned so far this year. And we also are available for some more personal hands-on technical assistance sessions. If you want, just reach out to me about your needs and we can have some conversations about that. Our upcoming workshop is on imputation strategies for racial and ethnic data disaggregation. Mark Elliott of the RAND Corporation will be presenting, and that is on Friday, October 8th. If you have registered for this one, you should also be registered for that one and should get a reminder. But if you don't, please just reach out to me. Now for today's conversation. This is about the decision-making processes that goes into deciding about your disaggregation strategies. Who are you going to disaggregate to try to capture? What are you going, how are you going to approach that? What kind of information are you looking for? And when is the right time to do that? And we have an excellent set of panelists today to help walk us through the types of decisions that need to get made, share with us some of their past decisions that they went through, and talk about some of the outcomes. I am going to turn this panel discussion over to the director for the Center for Health from the UCLA Center for Health Policy Research, who is going to moderate today's session, Dr. Ninez Ponce. Dr. Ponce.
Thanks so much, AJ, Dr. Scheitler. And welcome to our seminar series in the National Network, which is based at the UCLA Center for Health Policy Research. And at UCLA, we pay respect to the Tongva peoples as the traditional land caretakers of the Los Angeles Basin and South Channel Islands. Our lineup today is amazing. It's a fantastic group of researchers that will share their approaches to data disaggregation. Samantha Artiga, who is the Vice President, Director of Racial Equity and Health Policy Program at Kaiser Family Foundation. She'll be speaking on the implications of data gaps and limitations for health equity. Joshua Quint, who is an epidemiologist in the Hawai'i Department of Health. And rounding this out is Eva Wong, who's epidemiologist at a large county up north, public health in Seattle and King County. So let's get started, and let's start with Samantha Artiga. Samantha, as I said, is the Vice President and Director of Racial Equity and Health Policy at KFF, at Kaiser Family Foundation. In this role, Samantha leads Kaiser Family Foundation's work to provide timely and reliable data, information, and policy analysis on health and healthcare disparities affecting people of color and underserved groups, and efforts to advance racial equity in health and healthcare. I know I have gone to many of the works of Samantha, particularly in the disparities framework in healthcare, and I know many of you have as well. Her work focuses on the intersection of racism and discrimination, social and economic inequities in health. She has conducted extensive work related to the health and healthcare needs of low-income populations, immigrant families, and previously served as the Associate Director of Kaiser Family Foundation's program on Medicaid and the uninsured. Ms. Artiga holds a master's degree in health policy from George Washington University. So Samantha.
Thanks so much for having me here today to participate in this great discussion. Just give me a moment to share my screen, and then I will look forward to sharing this information with you. Okay, great. So as was mentioned today, I want to spend a little bit of time talking about the importance of data disaggregation efforts to equity efforts, highlight some of the current gaps and limitations in data that allow us to do that, and then end with some thoughts on strategies and different methods to help address those gaps and limitations. Before I dive into all that, though, I just wanted to give a little bit of background on my organization, KFF, in case some of you on this call may not be familiar with us. We are a nonprofit organization that's focused on key health issues affecting the nation. Our work spans a number of different types of areas, including policy analysis. We have an in-house polling and survey research team, and I'll be talking about some of that team's work as part of my remarks today. We have an editorially independent journalism arm, which you may have heard of, called Kaiser Health News. And we also have some public health information campaigns, including some that have been recently focused on COVID and COVID vaccination. As was mentioned, I head up our policy analysis program area that is focused on racial equity and health policy. And really our role here is to provide timely and reliable data and analysis on health and healthcare disparities, educate and increase awareness and understanding of disparities, and analyze the implications of policy changes on disparities and efforts to advance equity. All our material is publicly available on our website at kff.org. So if there's anything that's of interest to you today, you should be able to find it on that website. So I just want to start with setting the stage of why data is so central to efforts to advance equity. And really, it just comes down to the fact that we cannot address or improve what we cannot measure or see. So having high quality, comprehensive, disaggregated data is pivotal for our ability to understand where disparities are, to understand the multiple intersectional factors that are driving those disparities. The data can then be used to help direct and guide resources and efforts to address disparities and advance equity. And it can also be used to establish measurable goals associated with equity, which creates accountability then for moving the needle to address disparities and improve equity. Similarly, we can use the data to help identify effective strategies or best practices to advance equity. So despite the importance of disaggregated data for equity efforts, there have been long-standing gaps and limitations in data that allow us to do all the things I mentioned on the previous slide, particularly data that is disaggregated by race ethnicity. I've highlighted some of those major gaps and limitations, many of which we have seen really highlighted in data related to COVID-19. The first is really just the lack of publicly reported data that is disaggregated by race and ethnicity in some data sets. And we saw this very clearly in COVID data when at the outset of the pandemic, there really was very limited data available by race ethnicity in terms of understanding health impacts of COVID. There continue to be some of these gaps. We've also seen some of the gaps in terms of understanding who is and who's not being vaccinated. One common problem that we see, and we see this in COVID, but we also see this in broader data sets and surveys, is insufficient data to be able to speak to the experiences of smaller population groups or subgroups of the broader racial ethnic categories. In particular, this is a common challenge for understanding the experiences of American Indian and Alaska Native people, Native Hawaiian and other Pacific Islander people, and an ongoing challenge for understanding the diverse experiences of subgroups of populations that are all included in the broad Asian category. Another common challenge we see is inconsistency in racial ethnic classifications across different surveys or data sets. So although OMB has established a set of broad racial ethnic categories that are recommended to report by, we don't always see those classifications being used. For example, we continue to sometimes see Asian people combined with Pacific Islander people into one category versus into two separate categories. We also see variation in how data is reported in terms of race and ethnicity. So in some cases, racial categories exclude Hispanic people. In other cases, Hispanic people are included in the racial categories. So the separate reporting of race and ethnicity is sometimes treated differently across data sets. Another thing we've seen particularly recently is growing shares of people categorized in multiracial or other categories. And I think this is going to be an issue that's going to require increasing attention in the coming years, given the diversity of our population and the shares of people who fall into these categories increasing. So really giving some intentional and careful thought to the most effective and useful ways to categorize or report people who do identify with multiple different categories. We've also seen incompleteness of data. This again has really been highlighted in COVID, where in some cases we've seen race ethnicity missing for half or more of records in some of the data sets. So that is an ongoing challenge because we don't know how those missing data would influence the patterns that we see. There are some lags in data reporting, and oftentimes data are reported in ways that don't allow for analysis of intersectional factors to understand how multiple factors may be driving disparities. For example, being able to look at the data by both race and age, not only across those single dimensional factors. So given those gaps and limitations, just a few thoughts on some of the things to be thinking about to address those data gaps and limitations. The first really just starts with prioritizing data collection and reporting and really doing so in a way that allows for complete data disaggregation or disaggregating to the greatest extent possible. The second is really increasing the availability and accessibility of public data. So for example, there are some state level COVID-related data that are still not being made publicly available through CDC. So really, again, where the data are available, reporting it at the localized level to the greatest extent possible. Really focused and intentional efforts to expand the data available for smaller groups and subpopulations of the broader racial ethnic categories. In some cases, some of the limitations in the data we see are being driven by limitations in the actual underlying reporting systems and structures or data collection systems and structures. So thinking about how to modernize those systems and make them more flexible may be another strategy that is important for allowing for data for greater disaggregation. Increasing standardization of data reporting to address some of those inconsistencies that I mentioned. Another area where we have actually seen some movement recently is outreach and education to providers and individuals about the importance of data collection and reporting, particularly reporting of race ethnicity. This could help address some of the incompleteness or missingness of race ethnicity data in particular, making individuals feel more comfortable reporting those data. Those data have often been optional elements for reporting. People may be hesitant to report that data because they're not sure how it's being used. So increasing education and understanding about how those data are being used, how reporting that data can be helpful versus hurtful, and really emphasizing the importance of having those data available can all help address some of that incompleteness of data. And then really the establishing some requirements for data collection and reporting could go a long way in addressing some of these issues as well. So I just wanted to highlight a few things we've done at KFF along these lines to help address some of these issues. So as I mentioned, we do have an in-house polling or survey team that has been conducting ongoing surveys. They, as part of, for example, our COVID-19 vaccine monitor, which is an ongoing monthly survey we've been conducting over the course of the pandemic, they have oversampled Black and Hispanic adults to be able to speak specifically to their experiences throughout the pandemic and to really be able to analyze and understand the experiences of subgroups within those populations. So for example, in one of our recent surveys, we really focused on the experiences of Hispanic adults, and the survey was designed in such a way that we were able to drill down and really understand the varied experiences of Hispanic adults and how those varied by different factors, including immigration status, age, gender, parental status. So really having sufficient sample to be able to dive down and understand those more nuanced experiences within the broader group. We have faced ongoing challenges being able to really complete a comprehensive survey of the Asian population and be able to similarly understand those diverse experiences. In particular, cost has been a major challenge that includes translating into multiple languages that are needed to conduct a survey. However, we've moved forward recently by partnering with a community organization, the Association of Asian Pacific Community Health Organizations, to conduct a survey of their Asian patients at several of their community health centers. The clinic staff helped to translate and field the survey. They also were able to provide input into the survey design and questionnaire to make sure it helped address their needs. And so while this was an imperfect survey because we did not have a representative sample, it did allow us to get better understanding into the experiences of a population group for which their voice is often missing as part of the policy discussion. So I think in this case, it's really not allowing perfect to be the enemy of the good and moving forward with a project that allows us to give voice to a group that is often missing from the discussion, even with there being some limitations in the survey design in terms of relying on a convenient sample here. Another strategy that I want to highlight is that when data are missing or not available to be able to report for a group, instead of just not reporting those data, we purposefully highlight the fact that those data are incomplete, missing, or not available to be able to report for that group. And similarly, often we'll highlight in the text the data gaps and limitations that prevent our ability to be able to describe the experiences for certain populations. And so that is something that we've been doing consistently across our work, is to really try and highlight where there are data gaps and limitations that inhibit our understanding of experiences for some populations. So going forward, I wanted to highlight that even with the best of intentions, efforts to disaggregate data, are influenced by a variety of factors, many of which I've highlighted here on this last slide. I think the speakers that are following me will do a great job speaking to how they have navigated some of these factors as part of their successful efforts to disaggregate data. So I'm really looking forward to hearing from them next. And with that, I'll stop.
Great, thank you so much, Samantha. So the organization today is we will have the three speakers speak, and then we'll have a discussion at the end. But we are going to answer some clarifying questions, one or two after each speaker. But for example, there is a question right now that's posted by Bethany that I think I'd like the whole panel to respond to. So we're going to wait on that. So are there any clarifying questions? I don't see any on the Q&A. And if you have a question on chat, please put on Q&A. The comment from Mitchell is also another good question to ask for all the panelists. So we'll hold off on that. So with that, thank you, Samantha. And we're going to head way west to from the East Coast to Hawaii to Joshua Quint. And Joshua is going to talk about disaggregating race, ethnicity, COVID-19 data for Hawaii. Dr. Quint has worked as an epidemiologist in the Disease Outbreak Control Division of the Hawai'i Department of Health since 2017. He received his MPH, Masters of Public Health, and doctorate in epidemiology from UCLA, working on the multi-center AIDS cohort study under the guidance of Dr. Roger Deedles, a very distinguished, beloved colleague of ours at UCLA. During the COVID-19 response, Joshua has supervised a team of epidemiologists who manage Hawaii's COVID dashboards, digital exposure notifications for contact tracing, and epidemiological analysis of risk factors. So Joshua, tell us what you've been doing in Hawaii.
Great, thank you so much. Appreciate the invitation. It's an honor to join. I think out of all the panelists, I probably have the least expertise and experience in this, but I'm hoping that sharing our experience here in Hawaii and the sort of crash course that I had in having to disaggregate race, ethnicity data somewhat on the fly, having to scramble and look for creative solutions to overcome some of the barriers will be helpful to many on that are listening in today. So it is somewhat of a happy coincidence that I'm a graduate of UCLA and UCLA is hosting this, but also probably not a coincidence because I think UCLA really does an amazing job of training their students to value health equity and social justice. And then also definitely appreciated the UCLA Department of Epidemiology giving me a really strong grounding in statistical methods for causal inference. So with that, I came to Hawaii about 4 years ago and to really work on applied infectious disease epidemiology. A little bit of the quick background of race ethnicity in Hawaii is nearly a quarter of Hawaii's population is multiracial. So most states, Alaska would be the next most multiracial state population has 8%, and Hawaii is up there at 24%. So as Samantha mentioned, and certainly appreciate the work of Kaiser Family Foundation to set standards and provide the data landscape so that we can really see what the bar is to reach. But this is something that the whole country is trying to understand. What does this mean moving forward? And Hawaii is kind of at the forefront of grappling with some of these data statistical issues. Another salient factor is the population is represented by persons from the Pacific Islands, and they are certainly not a monolith. They represent a extremely diverse groups of peoples who come from unique and different histories, cultures, and languages, and can and should not be treated as just one single group, as we'll see. Coming from UCLA with that strong grounding in epidemiological methods, I was really looking for some guidance and found it on page 217 and page 303 of the Modern Epidemiology 3rd edition. And these have been some guiding principles that say if data are abundant, it is nearly always preferable to preserve the many categories. And some specific guidance that's in the text there are that categories should make sense based on external information. Categories should be defined so that important differences in risk exist between categories, but not within them. Categorize the data much more finely than necessary at first, and then categories can be collapsed together when data are sparse, as long as these combinations do not merge groups that are disparate with respect to the phenomena under study. So these are some of the methodological and analytic principles that I attempted to follow, but as again, Samantha mentioned, a lot of times you're not going to be able to follow what I would say are best practices here, but just kind of thinking through challenging that things are often done because that's the way they've been done, and that's not necessarily the most appropriate or relevant way to approach the data. So a couple key process factors that really helped us through our experience. I'll say in coming to Hawaii and growing up in Los Angeles, as well as having my training in LA, I felt a certain comfort with demographics and doing analysis of diverse populations, but I was quite unprepared to work with data of Hawaii's population because it is so unique and so different from any population data I had worked with before. And so 3 of the really great strategies that helped as we encountered the new challenges presented by coronavirus were to engage with community organizations, to leverage existing institutional resources, and to partner with trusted experts. And one of the themes that came across in some of my community engagement with a COVID response group was a theme that they would reiterate each time, for us, by us. And that was something I really tried to take to heart. There's a long history of colonialism, of people doing research on populations instead of with populations. And so that was definitely another guiding principle. Some of the timeline and the history of how COVID was presented and how we faced that challenge. The first case in the United States was diagnosed in Washington State in January of 2020. It was associated with travel from Wuhan, China. Fast forward, New York, Los Angeles, and other jurisdictions began reporting health disparities, primarily among Black and Latino and minority communities. And the first case in Hawaii was diagnosed in March, and they were associated with travel to the continental United States. So early on in the pandemic, the travel was the predominant risk factor, but we did see once the disease became endemic in communities, that risk factor profile definitely shifted to focus on some demographic and social determinants of health driving risk. I want to shout out to King County because their early report on NHPI disparities and demonstrating the high case and death rate for among NHPI compared to all other groups really prompted the need and emphasis to perform similar data disaggregation in Hawaii. And so we began reporting race ethnicity data, but as you'll see, our first reporting aggregated many of the groups, and that really began our effort to further tease apart and better understand what was going on. One really key step here in May was that DOH, myself and my team joined the NHPI COVID response team, and we saw that this was a challenge. Many places, they either have too sparse or don't have the infrastructure set up to provide reporting on Native Hawaiian, Pacific Islander, and other disaggregated Asian subgroups. So it was a common challenge. And finally, in June of 2020, 6 months after the pandemic start, we began reporting disaggregated data. So this was the first 1.0 iteration of our race ethnicity. The gray bars here, you can see kind of the demographics of the state. So using the OMB minimum categories, 37% would be Asian, 26% would be white or Caucasian, 10% would be Native Hawaiian or Pacific Islander, and you'll see this other group over here, 2 or more races. So that was our first attempt to share race ethnicity data and begin considering it as a risk factor. There were not any major disparities that emerged at that time, probably because as it was still in April at that time, risk was primarily driven by travel history. However, that would quickly shift when the disease became endemic in the state. And with this categorization, it was just simply not appropriate, not relevant for the Hawaii demographic population. So there were three key things that we had to do, three opportunities, I would say, for disaggregation. One is to disaggregate the Asian group, two is to disaggregate the NHPI group, and then three, the two or more. Each of those are quite large populations. Very, very early on, when there was just 100 or 200 cases, it would be difficult to disaggregate because of sparse data. But eventually, as time passed and the disease became more prevalent, we definitely didn't have the sparse data excuse anymore. And so we really needed to have better definitions. That process finally culminated in the way we present the data now. For our public dashboard, we have these 9 mutually exclusive groups, separating Native Hawaiian from Pacific Islander and disaggregating many of the Asian subgroups. We also look even deeper than these groups. We stratify further. However, for reporting, we do end up with some sparse data or too many categories. We do have several reports coming out that provide more disaggregated data even than this. So just to really quickly kind of review some of the barriers and strategies we encountered, as I think they could be helpful for other jurisdictions and agencies trying to determine once they've set the goal of further data disaggregation, what tools were most helpful for us in Hawaii and what may be helpful for others. So certainly political will, and that is, having decision makers who, with the preference to perform the data disaggregation, because it is not an easy task, and the local response team was instrumental for that. Having data collection tools. So we had the revised CDC form. We had to localize it because a national federal tool won't necessarily be tailored to the local situation. Having data systems. So being able to collect it and have a form is one thing, but being able to receive, process, store the data is another thing. So having our CDC race value set was very helpful. The population reference data, it's one thing to count people, but then to construct rates and identify disparities, you need data collected about the population that can be made for comparisons and reference groups. And then finally, understanding how to report the data, the construction of advisory groups to share the data first, and then understand how to contextualize. So in our experience, when it came to engaging with community organizations, we had a COVID response group that was formed by a collection of agencies. I just listed 3 of them here. There were many, many more. So Papa'ololokahi, We Are Oceania, Office of Hawaiian Affairs, being some of the groups that were very instrumental in helping guide our process. In terms of leveraging existing resources, found out that there were other divisions within the Department of Health that were already doing amazing data disaggregation. And so just reaching sometimes just down the hall to people and asking them how they're doing things and being willing to ask for help. And then finally, partnering with trusted experts. So people from the John A. Burns School of Medicine, Native Hawaiian Health, Office of Public Health Studies, and even the CDC Office of Minority Health and Health Equity. Finally, some other guiding principles through our process where we really wanted to promote accessibility. So using interactive data tools was really transformative. Striving for transparency, recognizing that the data that we're collecting does belong to the public, and so that need to share it back. And some other questions that I'm sure we'll get to in the Q&A, things like, well, how granular and detailed? One of our guiding principles there was to consider the relevance to the question at hand and whether you have the appropriate sample size to provide good estimates. Thinking about what are we actually measuring, remembering that race is a social construct and we're actually measuring more identity and culture than any biological principle. and how are race and ethnicity defined and interpreted, considering how the data was framed during the data collection process, and as well as when presenting the results. And then finally, how do we avoid perpetuating racism? This was a challenging question because some of the groups that are historically marginalized, they've had experiences of the data being used against them, particularly in the context of something like an infectious disease. So we had to really think through and talk through with our community partners, how do we reduce or avoid stigma and blame? And one of the keys to this was providing the historical context. Some key outcomes from from doing the data disaggregation was the formation of the NHPI investigation and contact tracing team, led by Chantal Montagui, staffed by members of the impacted communities. There was a collaborative report published by the Department of Health, which details community-led efforts, provides recommendations, and a framework was set up to that led and guided the vaccination outreach, as well as is guiding the current surge response in Hawaii. So future work, we have spun off a work group to further define and develop data disaggregation standards. There will be an Office of Health Equity revitalization in the Department of Health, as well as publication. So finally, I just want to thank all the people, the shoulders of giants who I stood on, because I came here with really a lot of lack of knowledge, a lot of ignorance on the topic. And so the folks here who have been doing the work a lot longer than me, just, Keave Kahulukula, Sherry Daniels, Lisa Watkins Victorino, my team at Department of Health, Sarah Kemble, Kealohi Washington, Haley Maeda, Chantal Matangi, and many, many others who really guided my work. And I'll share some resources that will be available in the chat. And that's it for my presentation. Thank you.
Great, thank you. Thank you so much, Joshua. Is one of your resources the CDC guidelines? I'm just wondering if you could also share that in chat that you referenced, the revised CDC form on reporting guidance on race.
Oh yeah, I can share that. So what it was is taking the federal version of the form, localizing it to have a Hawaii version of the case report form, and using just an editable PDF. So I can put a link to that in the chat as well.
Great, I think that would be useful for some members of the audience who may be coming from other states. Thank you. And let's see, any clarifying questions? Just again, looking at the chat.
Again, I think the question that's in chat that we're hoping will go into Q&A is probably one for everyone to answer. So nothing clarifying at this time.
Okay, there is one that just popped up, AJ. How did you use the CDC race value set, Joshua?
Yeah, so that's a great question. With the coronavirus, the data, primary point of data collection was during the case interview. So all cases were mandatory reportable to the Department of Health. And then throughout the pandemic, we have reached and done a preliminary brief interview at the very minimum with every person who's diagnosed in the state. And during that time, we're able to collect detailed race, ethnicity, and the value set. I have a slide here, I'll share it again, how it implements into our system. And this is really the importance of having good data systems to receive the data, because you can build any form. On the right-hand side here, this is how our disease surveillance system captures data. So it's a series of drop-downs where the OMB minimums would be captured as the first level, and then the subgroups there are at the second level, with the ability to add as many races and ethnicities as by. And so on the right-hand side here, these are the value sets with the associated HL7 coding. And so these would be the options under, for instance, under Asian, this dropdown would become available, and then under Native Hawaiian or Pacific Islander, these options on the right would become available. And we felt this list was maybe not perfect, but quite exhaustive for our purposes.
Okay, thanks so much. And we'll get to the other questions, because I'm sure all the panelists will provide some valuable insights in answering those questions. So we're going to go now to our third speaker, Dr. Eva Wong. Dr. Eva Wong, again, will talk about data disaggregation for equity, examples from King County, Washington. And again, Eva, a shout out came from Joshua on King County being one of the first to report the highest rates of COVID cases and deaths were among the Native Hawaiian Pacific Islander populations reported in the state of Washington. So Eva is a senior parent and child health epidemiologist with the Assessment, Policy Development, and Evaluation Unit of Public Health, Seattle and King County. She's also a clinical assistant professor in the Department of Epidemiology at the University of Washington. In addition to co-leading the Best Starts for Kids evaluation, which she'll talk about today, she serves as a senior epidemiologist and evaluation lead for programs within public health in Seattle and King County. Dr. Wong works with internal public health programs, students pursuing public health and nursing graduate degrees, and is honored to work closely with local community-based organizations. I think we're hearing a theme here across the speakers. She holds a BS in engineering from Cornell and an MS in environmental health and PhD in epidemiology from the University of Washington. I'd like to welcome Eva.
Thank you so much. So can folks see those slides now?
Yes, we can, Eva.
Great, thank you so much. So we've had some really amazing speakers and really important foundational understanding of this topic. And I just want to share a project from King County. This will be a parent and child health project example. Shout out to all the other state and local, federal health departments who've been working, because for all of us, COVID has not been instead of our existing work, it's been on top of our other work. So this is an example of some other work that's been going on the whole time. So for those of you who are not familiar with King County, we're actually in the Pacific Northwest. We are located on ancestral Coast Salish land, especially the Duwamish, Suquamish, and Muckleshoot tribes. We have a population of about 2.3 million, and it's the largest county in Washington state. We have 39 incorporated cities. The largest and most well-known, of course, is Seattle, Washington, as well as a number of unincorporated areas. Sometimes we talk about a tale of two counties. So in King County, even though overall on our measures of health and well-being, we look really good, we actually see a huge amount of disparities, whether it's life expectancy, access to healthcare, income, all the different social determinants of health, or thinking about physical and behavioral health risk factors and outcomes. Like many of you, we're really starting to look at Census 2020 data. It's just starting to come out. So our county is only growing more and more diverse. Hat tip to our local paper, the Seattle Times, which looked at the race and ethnicity for the state, and then King County on the bottom. We're approaching 50% Black, Indigenous, or people of color here in King County. We also see increasing diversity among children. So that's as we think about children who report more than one race, and that increasing diversity, it's just the forerunner of that is among children. Equity has been foundational to our work here in Martin Luther King County for a number of years, if not decades. And like many other jurisdictions in 2020, we declared racism as a public health crisis. So what that means in King County is that we're going to focus our efforts and center the voices and lived experiences of Black, Indigenous, and people of color. One example and one way that we have been centering equity in our work for a number of years is this initiative called Best Starts for Kids. And so in this initiative, it's a 6-year initiative focused on ensuring every child in King County is happy, healthy, safe, and thriving. However, we didn't have any data on local conditions. We didn't know, like, when we think about healthy, how many kids are saying that they're in really good health? So we actually had to field a local survey to get at some of that data. And that's what I'll be talking about some more here. So this happens to be a local survey. It's responded to by parents and caregivers of children in 5th grade or younger. And it really focuses on the strengths, needs, and supports of children and families. So things like child well-being, parent-child connection, school experiences, basic needs, things like diapers are a huge issue for families. as well as demographics. So we have done this survey 3 times now, with the third one it's actually currently in the field right now. It's going to close right after Labor Day. And in terms of the demographics, we have a suite of demographic questions, but in terms of race and ethnicity, we actually asked the parent to respond and offer 18 different checkboxes. We also offer a write-in option. So, and these are select all that apply. One of the things you'll note is Middle Eastern or North African is in that group. When we were starting to field this survey, this was right about the time that at the federal level, they were trying to think about, do we offer Middle Eastern North African as a specific group? And we decided to go ahead and just say yes, even though we knew it wasn't a huge group. So there's checkboxes and then there's write-in information. We code that write-in information to put responses into one of the existing options if we can, or sometimes there's responses that we can't code. Mutt or Heinz 57 are really common responses that we can't code into anything else. So in addition to offering this survey in 7 different languages, so we offer it in Spanish, Chinese, Vietnamese, Russian, Somali, and Korean. We support equity and disaggregation of race and ethnicity by having 3 different modes. So people can do it on the phone, they can do it on a piece of paper and fill it in, they can do it online. And we do see differences of who participates by mode. So it's really important to have more than one mode. We also oversample by race, ethnicity, and geography, specifically geographic areas of our county that we know have an overrepresentation of Black, Indigenous, and people of color. We also have 13 cultural, community, and language liaisons. So they not only help us think about some of the questions, review the translations, then they also answer questions from the community and act as ambassadors for the survey. Again, we have these detailed race and ethnicity questions, and then we actually take the results and then we bring it back to some community groups and we bring it back to them to say, what do you think of this? So in terms of the data collection, I just talked about that. This is really around the presentation. Our goal is to share as much data as we can. So online, we present all the demographic characteristics and we share out the standard Office of Management and Budget, those big race categories, but we also share all of that detailed race ethnicity information. Joshua mentioned they're using Power BI and Tableau. We use Tableau to help with the data presentation. Obviously, it's a huge amount of information. This is the detailed race ethnicity category. It's online. So there's 23 different bars. It's obviously a lot of information. But using some of these online tools, it allows you to filter or just look at some groups and just pull out the information that you need. We do happen to have a small numbers algorithm. So we do suppress the data that's here if we have less than 50 responses to protect confidentiality or report reliable rates. And then finally, disaggregation matters. We work with our local community partners, particularly for communities that we haven't presented data for before, or actually for some of the data that don't meet our data reporting thresholds. We've actually worked with community partners to do data dives. So we work together, they pull together some families, we get together and we talk about like, does this meet with your experience? Does the data resonate with you? And maybe it doesn't, and we'll try and find out why. Sometimes we call them data dives. Sometimes they're also referred to as data parties. But it's just a chance to get together before COVID with food, with childcare, stipends, just talk about the data and what it means for them. So just to summarize a couple of different things, really, we see this as a way to incorporate our equity values into how we do data collection, data analysis, and data presentation, and incorporate community voice at every single step of the process and iterate on that and use that information to inform the next round of our surveys. We really focus in on being a facilitator, not a gatekeeper to data. And we think these online tools can support. Sorry for the background noise, if you can hear that. changes we've made in subsequent survey cycles includes things like collecting Hispanic as a race. So in our first iteration of the survey, we actually collected Hispanic as a ethnicity only. And then we did our bridging where we collected it as Hispanic as an ethnicity as well as a race. And then more over time, we've just collected Hispanic as a race alone. And it's yielded some surprises when we look at the write-in information. We didn't think that we had a large Dominican population, but we actually had enough to be able to report out on that group. And then just to wrap up, I want to acknowledge the 16,000 parents of King County who've reported in this survey. This is a publicly funded survey, so wouldn't be possible without the residents of King County. I want to thank the huge teams at the University of Washington who actually field this survey on our behalf, as well as our community partners and other staff. This is the dashboard that I mentioned before, so you can go there to find more information or email me for more questions. Thanks.
Great, thank you. Thank you so much, Eva. And I wanted to thank all the panelists, Samantha, Joshua, come back, please, and Eva. So there's a few questions, but I'm gonna start us off. There definitely was this theme of that, this data equity is an important piece to address the inequities that we have in our healthcare system and across society. And I think, Samantha, you laid out already, what the action steps should be and what it would take. And so I just wanted actually to start with that because I think that there's, definitely the audience here and the people in the room are keen to learn more and are, have the motivation to do something, but there's obviously pushback because we're not seeing, more granular data or race ethnicity data, even at the minimum OMB standards. So there's pushback. So, what does it take? I guess I'm going to ask first Samantha to like explicitly measure disaggregated data in the surveys that you were running. And also, Samantha, since I know you use also several different data sets in your work, what would you like to see more, in your work?
Well, I think we're actually in a really important moment in terms of having an opportunity to really push forward on data disaggregation. One of the outcomes of COVID and the pandemic has really been the greater recognition and awareness of disparities and a growing call to action to address those disparities. And so I think we are in a moment where there is a lot of interest in addressing disparities, increasing equity. And so the extent to which we can highlight the need for more disaggregated data as a pivotal component of those efforts, we can hopefully get more resources and prioritization focused on disaggregating data. I think in terms of what I would like to see, and you're right, we use a lot of publicly available data sets, both survey data sets as well as administrative data sets. And I think, again, some of the things that I personally have found most challenging is the lack of consistency in standardization across those data sets. It just makes it very difficult to do any comparisons. With the COVID data, a lot of the inconsistencies are across states in their different approaches for reporting. Again, the different racial ethnic classifications, how you're treating Hispanic versus non-Hispanic, and whether you're combining that with race or not. And then the other issue is, I think, the two key outstanding issues that I think really are going to be important to address going forward are getting better data to understand the experiences of smaller population groups and subgroups of the broader racial ethnic classifications. I think we for so long have just been saying, well, we just can't because cost and it's too difficult to get sufficient sample. And I think we're reaching a point where we need to figure out strategies to overcome those challenges so that those voices don't remain missing from the reported experiences anymore. And also just pushing back against talking about diverse populations under a monolith of one broad category. And we've seen this long challenged among the Asian population, who has highlighted the fact that that reporting as a single category masks many underlying disparities among different subgroups. But this is not an issue that's only among that population. It's among all the broader racial ethnic classifications. And then the last point is I really think we are in a moment where researchers, policy experts need to be thinking about how we are going to report for the growing numbers of people who identify as multiracial. And as Eva mentioned, we're just at the forefront of this as an issue, because the children's population is even more multiracial than the adult population. And if we continually just clump people into a broad multiracial or other category, we're going to lose the ability to really be able to understand the experiences of a growing share of the population. And so I think it's important that we start having discussions now about different potential approaches or strategies to report data for people who identify with multiple categories, and really having some thoughtful discussions about it.
Yeah, thank you. On multiracial, in Joshua, I mean, you said, was it like over a quarter of Hawaii's population is multiracial? What's your guidance on?
Yeah, and I wanted to speak to the concept of small populations, and then I want to talk also about multiracial, because I think one of the issues is that you can statistically hide behind statistical non-significance and say, well, the estimates are unstable, therefore, and realizing that type of rationale perpetuates marginalization, because it's these smaller groups that have been marginalized because of their size. And so recognizing that, is that an absolute constraint or a constraint within your sample, and not using that as just a blanket reason to not disaggregate. So attempting to disaggregate first, collecting as granular, detailed as possible, and only aggregating up, collapsing up as absolutely necessary. When it comes to the multiracial, Hawaii is, as I mentioned, at the forefront in terms of the demographics and the demand. It's an absolute necessity to do that. And I have two answers to that. One is in terms of leveraging the existing resources. There is a standard that we found that's within the Department of Health that we hadn't been implementing in our division. So it was new to me, but it was not new to Hawaii, and that's through the vital records. So the way that births and deaths are categorized, there's some preference to put people into one of mutually exclusive groups so that your denominator adds up to 100% and people are not counted in twice or more than once. And so we have an algorithm that we apply that allows us to sort people who are multiracial, and we follow that algorithm. And then we're also exploring other ways. If you can permit that mutually exclusive or 100% denominator is not an absolute constraint, then we've been exploring the race in combination. So preserving each individual's multiracial identity and looking at them kind of one at a time and allowing people to be multiply represented. But that's actually all right. You can calculate rates. You don't have to define disparities in terms of 100% of a group compared to the population representation. You can just divide by the denominator of people who identify with that in combination. You don't have to use just alone.
Oh, that's really useful, Joshua. Yeah, I think there was a question, I'm trying to find it, about, it's the first question by Bethany. How do you manage change over time with person level information? For example, forms across agencies also gets at the standardization too, not just across surveys, Samantha, but also over time it changes. And how do you reconcile inconsistent choices within person over time? Do you select affiliation with the rarest group as measured at a population level with a geographical area, or across those time points. I think that would also apply to Eva and Joshua.
Yeah, I think Eva and Joshua would probably be better suited to answer this.
So I can just share the example that we did with Hispanic ethnicity versus Hispanic race. So we actually did Hispanic ethnicity race in our first version, and then we kept Hispanic ethnicity race, including Hispanic as a race, in order to do a bridging for that year. So it was kind of weird for folks who did check yes on one of the Hispanic boxes, because then they also checked Hispanic under race. But that way we could statistically do some back calculation and put it all into one standardized category. But we really moved towards Hispanic as a race, just because locally, when you look at the write-ins, people were writing in a lot of Hispanic under race. There's a lot of confusion, and just based on our community feedback, it didn't make any sense to pull it out.
Yeah, I think it's the question of bridging, especially this occurred with when OMB Directive 1597 revisions, when they allowed to mark more than one for the multiracial, and then how to bridge with previous data systems that only had allowed for single race categories. And there were a number of approaches where do you tabulate to the largest group, the rarest group, as Bethany was suggesting. And so I think it does, I think some of those choices, it gets into choices, right? And so my question then is, I mean, Eva, you showed a lot of different categories in your survey, and with King County, Joshua, the pull down categories, there were a lot. I mean, who makes these choices on how granular you can get? And
Yeah,
Samantha too. Yeah,
I'll comment on that. And thinking about, how granular the choices, we want to present them with as many options as possible, so that people can find their identity in the list that they're presented in. People need to be represented and feel that they're checking something that is relevant and appropriate and applies to them. But I think someone mentioned in the chat, there's a question about now, how do you think about the burden that you're putting on the respondent then we don't want to be in this position of having to extract information out of people. We really want just a good alignment with the question at hand of what are we trying to measure, and what is our overall goal and objective and our priorities, and really limiting the burden. Something I've been hearing a lot is many of these communities are over surveyed and underserved, and so they do a lot of surveys, but they don't always see the fruits or the impact of that. Is it coming back to them, or is it just being used for pure research purposes? So definitely trying to reduce the burden. And then I think also a point someone made in the question was that race ethnicity it's flexible, and we shouldn't think of it just as discrete categories, but as something that it's maybe not even fixed. It may modify over time, and allowing people to have that flexibility to identify, because we really think if we're saying it's not a biological, it's not so much your genotype as your phenotype, or actually your behaviors and activities that you do, then that's also modifiable. And so just giving people that ability and permission to self-identify however they are.
okay.
I'll second what Josh was saying. And because we had some printed forms, we needed to also balance how much can fit on a page and still be legible. So we tried to find a balance between having enough categories that somebody can see themselves represented, as well as having that box. So like, okay, I don't fit in any of those boxes. Let me write down what I do fit in as.
So there's a write-in option. Okay.
Yes.
I'm going to go now. We have the questions are mounting, which is great. And for those of you who are posting in chat, I encourage you to put it in Q&A. So, because I don't monitor chat as much. So to make sure to increase the probability that your question will be posted to the panelists. I'm going to not even censor this, or I'm just going to go through this. Is there a line between getting a great amount of data and putting burden on the respondents for race, ethnicity, SES, et cetera. I think, Samantha, you sort of talked a little bit about privacy as a consideration.
I mean, I think obviously with surveys, there's always the issue of limiting survey length and burden for respondents. I do think that there also is this issue of a history of people maybe not necessarily feeling comfortable reporting race, ethnicity, or having some concerns about reporting race, ethnicity, given the history of how data have been used and how different population groups have been treated in the past. So I think there is a role for, as part of the research community, for educating people about the importance and value of sharing these data, explaining how the data are used, how they're protected, and why they are helpful and not necessarily hurtful to report. I think, you know, historically that race ethnicity option or question has typically been optional in many cases. I mean, you see that throughout life, that most forms that you fill out may ask for race ethnicity, but not necessarily make it a mandatory field. I've actually seen with some of the COVID data collection now that is a mandatory field. So that's, I think, another strategy that might be being implemented to some extent. But we've seen, for example, some of the states putting out public messages about explaining exactly why they're collecting the race ethnicity data. And I think also similarly, messaging is important for in the context of COVID for the providers, but whoever is doing the data collection, particularly if who is doing the data collection maybe have capacity constraints, kind of juggling a lot of things, emphasizing why collecting that race ethnicity information is also important for the data collection side of things as well, just so they understand the value of it.
Yeah, great, thank you. Carol Gilbert asked, should we consider disaggregating white more than we do? So we often divide by Hispanic and non-Hispanic already. What cultural divisions do whites have that affect health? Party affiliation example, not joking. So Eva, you said that you started, you know, you went beyond what's the Census 2020, you know, did. I mean, there was a lot of discussion in the national content test that actually looked favorable towards collecting Middle Eastern, North African, for example, and who are not exclusively white. They could identify with Black and other races. But tell us about what Seattle King County did.
Yeah, thanks. So, I mean, I spent a lot of time talking about the equity foundation for our work. So coming from that perspective, we wanted to disaggregate as much as we can. I didn't talk about it, but we also have a question on our survey asking about language spoken at home. And so using that, we also see a fairly large Russian population and a Ukrainian population that come forward, and we see some differences there as well. So I would say our goal has been, or our motto maybe has been, just disaggregate as much as we can to provide that information, because sometimes this is the only information that these communities have about the data.
Yeah, and I can say I also lead the California Health Interview Survey, and this year in 2021, we've put a write-in category, and I know that there's other discussion on write-ins, you know, the utility of write-ins. It does take time because write-in responses for surveys require, you know, processing this, and so we'll see. We'll share the results of what we find with the write-in category for whites. So Jeff, hi Jeff Brontiger from Colorado Health Institute says, asks, do you weight your data using race and ethnicity? And if so, against what sources do you calibrate? I like that question, Jeff. That was like one of my questions in my back pocket.
So I'm assuming that question is for me, since it's a survey. It is weighted. This happens to be a survey of children, if you'll recall. So we actually, we have our universe, and so we sample from that universe, and then we weight it afterwards. We actually do something that I hope is exciting and interesting, where we have our population weighted portion of our sample, and then we actually have, we call it the community-based sample, where we work with different community organizations and partners to say like, hey, we'd really love to get some additional responses from the LGBTQ plus population, or maybe the Somali population. Can you send it out through your listservs? And then we are able to incorporate all of that information together. Hopefully I've answered that question, but because we have our universe.
Yeah, I think, right. But Samantha, it also is conducting surveys. So what control tools do you use? What population?
So our survey team will weight the data by a number of factors, including race, ethnicity, and that's all using the ACS data and the American Community Survey data for now.
Yeah. So I'm going to say, oh, I'm supposed to do.
And I think there's a similar question about what we use for denominators, and we generally are using that ACS data as well for the denominators.
Okay, yeah, thank you. Some states have their own demographic branches, like in California, we have the Department of Finance. So we do use the Department of Finance demographic projections, but they don't go granular. So they have the 5 OMB categories plus race, plus Hispanic, Latino, ethnicity. And then we use the ACS distributions to get at the granular, to apply that with the DOF, Department of Finance totals. So let's go with anonymous attendee. What is the reasoning for some of ethnicities being collected together, for example, Cuban or Puerto Rican? I think we're all like, we want it to be disaggregated. So I'm gonna say, so I'm gonna just go to the next one, because I think all the speakers here, the proponents, are for the disaggregation. I think one reason is you may not have abundance in numbers. I'm going to say what Joshua said. So there's an abundance in numbers and a small population. That could be one of the reasons. Maribel Davila asks, what was the decision behind reporting Hispanic as race? Was that from the community? I think that is to you, Eva.
Yeah, it's very much so. It's a couple of things, definitely led by the community and what the community was telling us. And then also when you look at the write-in responses, Hispanic was one of the biggest things that people wrote in under race when Hispanic wasn't an option under race. So when you have the separate Hispanic ethnicity and then race with a write-in, it just, people get confused. It doesn't make sense.
Samantha, I mean, is that your experience too in your surveys?
We use the still the OMB classification approach in our surveys for collecting race ethnicity data. I will say that we have adopted a standardized approach across all our reportings, that all our products that we report racial categories as non-Hispanic, and anyone who identifies as Hispanic in the Hispanic category, regardless of their racial classification. So we use that approach consistently in all our reporting.
Yeah, and I think that's typical, right? In most government reporting.
It is, I thought it was typical. We've seen a lot of variation in that in the COVID reporting, in the COVID data reporting.
Right,
so,
the state by state COVID, right. Yeah, some in just reports race incorporating Hispanic, some have non-Hispanic, so it's mutually exclusive. And actually, Joshua, I think in Utah, they report, it doesn't add up to 100%. So for the multiracial, you get put in, you say you're Asian and you're white, then you get put both in the Asian and the white categories. Our team did so one concern with with having Hispanic and then everyone else non-Hispanic is that for smaller groups, particularly in California, with American Indian Alaska Natives who are, California was once Mexico, so and it was an indigenous land. So you have a large segment of American Indian Alaska Natives who are also Latino Hispanic, then they get put into the Latino Hispanic category. And so for smaller populations, then there's a big impact. So that is one concern with a Latino trumps all rule. So I think that's done.
I can comment as well on
sure.
that. On one hand, Hispanic ethnicity is not one that we've focused on, and I think it's an area for improvement. And our corollary is what you're describing as sort of a top coding. If Native Hispanic, then ignore race. That's actually how in Hawaii we treat Native Hawaiian ethnicity is if Native Hawaiian, then it doesn't matter what else. And for the purposes of reporting, categorization, and thinking about intersectionality, and that it may, depending on the question, the health question, it may matter, whether, and there are really good historical reasons why in Hawaii we top code Native Hawaiians, but also thinking through, whether it's relevant to the question at hand, and whether you can both preserve someone's Native Hawaiian ancestry and identity without removing or canceling out their alternate identity. So I really am interested in that in combination approach, as opposed to having to put everyone into one of mutually exclusive categories.
And I also want to add to that, we have a very small American Indian Alaska Native population, as well as a Native Hawaiian Pacific Islander and the Middle Eastern North African population here in King County. They're all really, really small, and have the American Indian Alaska Native and Native Hawaiian Pacific Islander population are both really, really small and multiracial. Just give a shout out to our colleagues at the Urban Indian Health Institute, where in our discussions with them, they really said, like, hey, it's super important to us that you report American Indian Alaska Native as one community, whether they're multi-race or not. And so that's what we're doing with as much as data as we can, is to report out American Indian Alaska Native as one community, more in that in combination, alone or in combination categorization, wherever possible.
Thank you. Carol and Jeff, let me go to, you asked questions. I'll try to get back to that. I'm going to try to ask questions from some other participants. So Erica Webster asks, I work in an agency that has a capacity to collect self-reported race ethnicity data from the people in our program, but then we don't have disaggregated comparison groups in the publicly reported race data that only show the broad categories. What are some strategies for comparing disaggregated data sets to the broad race data to try to understand how our program population compares? In short, is there a roll-up algorithm too?
I mean, I'll jump into that, because I think you should try not to roll up if you don't have to. And so really pushing through, because if you go to census.gov, it's difficult to find disaggregated racial data. So really digging in and can reach out to me, and I can share some of we use like an R code that implements a census API that lets us extract what Samantha was describing as the ACS data, which is incredibly disaggregated. So, and it goes down to really narrowly defined geographic areas. So, because as soon as you roll up, you may have to roll up, you may need to roll up, but as soon as you roll up, now you're aggregating, and now you've lost information. And so kind of pushing through, not using there's no disaggregated data available. It's just maybe it's difficult to access. So reaching out, leveraging partners, agencies, other experts that have found strategies for it.
No, I really like that, and Joshua, but I think Erica's question was if the other groups, like for example, also with federated data, states may collect more granular, but then when it goes to like vital statistics and it goes to National Center for Health Statistics, then it's it's the OMB categories. So again, having where do Afghanis go? Are they Asian, or are they white? So I think that that's the, the question is where would you put, how could you compare, at least from statistical convention, in the allocation of those groups? So is there, I think that, I mean, I see that Sue Babby has already, who's part of our team, has been our resource goddess here, who's been putting the links. So there is a roll-up from the Institute of Medicine report back in 2007 that actually consolidates some of the CDC guidance and census guidance into a roll-up. So I think that's a good resource. Let's go to, so Erica, Ed Fox asks, tribes as governments that have their own health systems or operated by the Indian Health Services could be a source of administrative data that could be utilized as a cross-check or control on survey data or non-tribal, non-IHS administrative data. The problem of small numbers would not be an issue if tribes agreed to share the data as they have for well-designed surveys. So a data match administrative data from Medicaid and IHS that includes all tribal patients would advance Medicaid research. Any examples of using IHS tribal admin data from the panel, or also a call out to the attendees who are here who may have experience in this? Panelists? Okay, I'm not seeing, oh, Eva?
This is an older example, but again,
Okay.
We have been incredibly fortunate to partner with the Urban Indian Health Institute, which is headquartered in Seattle, but of course works across the nation. And one of the examples that we did many years ago was we actually took their participants who went to their health clinics and looked at the death certificates and matched it. And we found that death certificates have a race listed on there, and we found it was heavily underreported for American Indian Alaska Native on the death certificate. So just a great example and a partnership that we've been incredibly fortunate to have in our area.
Yeah, I think this question, there's a lot of issues here too. It's about data sharing, concerns about data sovereignty, but also improvement of data systems like Medicaid, which may not have the best race. I mean, Samantha, ran the Medicaid program at KFF, may not have the best race ethnicity, and perhaps it could be improved. So I think it's a longer question. We're going to keep this and actually ask Mark Elliott, who does a lot of the race imputation on Medicare. I'm not sure Medicaid, but for sure the Medicare program. We'll ask him this question at our next seminar, which means all of you have to come back for that next seminar. Okay, so we have Sharon from New York City. For any given numerator data source, example, reported COVID-19, how do you go about compiling population denominators? I think that was what was mentioned here already. So, okay, so I will, Sharon, we've answered that already. From the New York HIV Planning Council, thank you for joining us. What suppression rules do people follow to decide when numbers are too small? We deal with HIV surveillance data, conserve confidentiality, particularly for data provider organization. Very quick, because I know, Eva, you said you have some kind of algorithm, 50 cells. Joshua, in our pre-meet, you said, well, with COVID, things just kind of went out, these rules of suppression sort of went out the door.
Yeah, I'll speak on that. I think there's two different issues, because one is could the individual be potentially identified, and some having just good data governance, data suppression rules, cancer statistics have some good ones, cell size and rate suppression rules. I think one of the suppression rules we've implemented in an upcoming publication is 10 and 20. So 10 for counts and 20 for rates, and that just sets a floor. But then also, if you're dealing with something that's potentially stigmatizing, I think bringing the results to the population that is represented in the data and asking them, how they would like, and it's not only their decision, but because in our example, early in the pandemic, we were seeing some Pacific Islander subpopulations. And so we had the data, but we talked to them about whether they wanted us to share that data publicly or not, and what would be the impact of sharing that data. Would it lead to stigma, targeting, blame for, as with infectious disease, HIV being another example, versus would us sharing that disaggregated data be a benefit to them and allow them to advocate for resources? So I think working with the community and how it's reported.
Yeah, and I think what you just said answered a bit Jose Santiago Velez's question about moving from markers to drivers of disparities in data disaggregation when we report race, ethnicity. And Jose, I think we'll answer some of this because I see some other questions are about engaging with communities. So I am going to say that we have answered that. Ed Fox, there's a clarification here. Perhaps the panelists can take a look at it and answer that, because I want to get to Natalie's question. Could you speak more directly about sample size limitation? Okay, I think we talked about that. And Neca Lundy de la Cruz asks, also, for groups that are usually collapsed, example, white and Middle Eastern, are respondents who select both considered white or multiracial? That assumes that we have a Middle Eastern category, right? I think that's a question, Neca, that we'll all be grappling with, once more. And actually, Eva, you actually have a MENA and a white. Where you don't collapse them?
We don't collapse them. We
Okay.
reported for that really big graph that I showed that had a lot of bars. We report people for whatever bar they're in, I guess.
Okay.
And I want to say something about collapsing, keeping in mind and maybe even making it apparent in the presentation of the results of when we have done an active collapsing step, or are we representing what the person self-identified as? So like, is other a self-identification, is multiracial a self-identification, or is that a analytic collapsing step? In which case then we're not necessarily portraying how the person originally identified it. And there may be reasons, valid reasons to do that, but also making it clear when you've deviated from the person's original identification.
Oh, I think we have 2 more minutes. Oh, we didn't get through all the questions, but have any of you worked on advocacy for the OMB, to make OMB changes? Samantha.
I mean, we don't, as an organization, we don't advocate or make specific policy recommendations. I think through our work, we have been trying to highlight the importance of data disaggregation for broader efforts to advance equity and identify and address disparities. And so that's what we're trying to do through our work, is really highlight the vital role of data and the necessity to have high quality disaggregated data to really do the work that's needed to address disparities.
Great, thank you. So we have 1 minute left. There are some questions, comments from the attendees. One of them is, have communities actually told you that for historical reasons, they were told that they had to, how many of you work with communities that have previously been told to report themselves in a particular way and have historical reasons for indicating they're part of a particular group who we want to now report differently? So I think that's a question. You can put that in chat if that's the case. Again, I think it emphasizes the importance of, again, nothing about us without us. And really understanding the community needs. So I'm sorry, we are at the top of the hour. We thank you for joining us today. I want to also thank the panelists, Samantha, Joshua, and Eva. And I hope that at some point we were close to 200 participants. that they were able to have some great takeaways. I would end with takeaways, but I think you already gave a lot of takeaways in your presentation and in the Q&A. So thanks so much. And we look forward to continue to follow your work, panelists. Thank you for all the valuable work, and that we hope that our audience will join us at our next seminar. October 8th, AJ? Is that?
Yes, October 8th at 10:30 noon. That is Mark Elliott walking us through strategies for imputation in dealing with increasingly disaggregated racial and ethnic data.
Fantastic. Yes, and there's thank yous coming up on chat, and we'll leave this open for another minute so that you can share your thank yous with our panelists. So thanks again. Wow, we're getting a lot of thank yous.